friend has a medical cannabis, and he says to his friend, look, you've got pain, try it. He has a 2% bioavailability, and the other one has a 56%. They are both using 23% THC cannabis, but you can understand the difference between the reactions 1 and 2. I will already say that at least in Israel, 15% of the patients who get permission to use cannabis stop it because of side effects. Most of the side effects can be treated easily if you have someone to help them, advocate them, instruct them, and even phone someone you can phone to. Yelena will speak to them about this subject at her session. The concentration, as you see, are nanogram per milliliter upon each single inhalation of 175 THC or 355% THC, which actually, concerning the usual doses of cannabis that at least we use in Israel, are quite small. After 2 hours, the concentration in the plasma was less than 5 nanograms per milliliter. Why is that important? It's important because according, if I'm not mistaken, to the US regulation that will be probably stated in Israel, one of the main questions is, are you allowed to drive under the influence? At least nowadays in Israel, according to the law, when being treated with cannabis, you are not allowed to drive, period. Because as long as you have cannabis derivatives in your urine, which is about 3 weeks, as you know, you are considered driving under the influence and not allowed. Medically speaking, it's wrong because we want our patients to go back to normal life. And driving is essential usually for most of us even to get to work. So one of the questions the patients ask us says, okay, I understand that according to the law, I'm not allowed to drive. But I want to know what's your decision. What do you recommend? What's your recommendation concerning driver? We took actually the Health Canada parameters that says that after 6 hours of any way of ingestion of cannabis, you will be allowed to drive, which means it doesn't matter if you take it by smoking, inhalation, or sublingual. 6 hours is usually the longest period of having active compounds in a plasma above 5 nanograms of THC or reliable products. So you can drive. As you see, the mean highest concentration, were very much larger, 20 times or 30 times as large after smoking a single cigarette of the same extract. CBD can modify the effects of THC, and we'll talk about it later. But when you use a combination of CBD and THC, the effect may be different. In Israel, at least at this time, most of the strains have only traces of CBD, if at all. So actually we're using not pure THC because it's cannabis, but high concentration of THC with no CBD. We are only now starting to use higher CBD concentration from 2% actually to 20% of CBD, but they are not as stabilized as the THC strains, at least at this point of time. Oral absorption, as I already said, is completely different. First of all, it depends on whether it's soluble in oil or soluble in water, which depends on the mechanism how you make the compound. It can be oil-based, it can be alcohol-based, and it depends on what you do. Absorption is much slower, and one of the reasons people prefer smoking is it works fast, especially when you start treatment. When you start treatment, you have to do a titration. A titration with smoking or inhalation is usually about 2 to 4 minutes. Yelena will talk more extensively on this, but usually give them an inhalation, wait 30 seconds, another inhalation until you can see some effect and the desired effect. While using oral derivatives, you have to wait days. I mean, you have to wait hours for the effect, which means you can't do it in the clinic. The patient has to call you every now and then, usually once a day or once in 2 days, and the titration period is much, much longer. Oral bioavailability is also smaller. If you remember, the smoking bioavailability was between 2 to 56%. Here it's 10 to 20%. So in one point of view, the window is much smaller, and it's better. It's easier to work with. But the total absorption rate, or the highest absorption rate, is much, much smaller than evaporation on smoking. And of course, that means you would use higher quantities of THC and CBD. As we see, the highest concentration peak 4 to 6 hours after ingestion. And this, of course, puts a question on our decision of being allowed to drive after 6 hours, because you might exactly be on the peak concentration. But most people will already be after the peak concentration and going down. As you see, peak concentration range from 4 to 11 nanogram, which is above what the 5 nanogram that has been decided as a level. I would like to show, if you saw in the previous presenter, there were a lot of derivatives that were made in sweets, chocolate, sour cream, cakes. Now, we know from medicines that the soluble that has the medicine itself is extremely important. And we don't exactly know what will be the difference in absorption when using a chocolate cookie or a vanilla cookie or a cherry cookie. Nobody checked it, although the producers give those things. As a medical doctor, I am opposed to this because we wish to know as much as possible exactly what we give and not to give derivatives that were not checked or products that were not checked. There are other forms that are less that we are less familiar with. One are skin patches or transcutaneous. They should improve the bioavailability since they avoid the first pass metabolism in the liver. They go straight inside the bloodstream. But we don't have enough, at least in Israel, we don't have enough practice with dermal patches. As you see, the steady state plasma level was maintained for at least 48 hours with a long-acting skin patch, which is actually very good if you can have a steady state plasma concentration, which we don't have with smoking and we don't have with other oral products. The drug use potential, of course, is very low. Again, since you have a steady state in the level in the plasma, usually a low one, much lower than a psychoactive concentration that you need for her to feel high or to have the psychoactive. And due to that, there's also a reduction in the negative side effects. We have now a few people that have clinical trials trying to use thermal patches in Israel. I don't know of how many clinical trials there are around the world concerning that. CBD. Usually, CBD is a lower concentration than THC, even when given the same amount, which means that even if you use Sativex, which gives about the same amount of CBD and THC in each spray, you will see lower plasma levels of CBD than THC. As you know, CBD not interferes, is a sort of counteractive to the THC, especially in the psychoactive part, which is very important for us as a medication, because one of the raison d'etre of cannabis, of CTP, is that our patients do not want usually the psychoactive part. Because when you take it recreational, in Israel it's usually a Friday, probably here it will be probably a Saturday evening, you don't really care if you'll have dizziness or you feel a bit nauseous, so you'll go to sleep. You're smoking until you feel comfortable with it, until you feel the high. A bit like drinking. While if you want to go to work, you don't want to feel the high. Okay, when we had a patient convention, and one of our patients is a financial advisor, and he says, he suffered from a severe backache due to a chondroma, and he said, I don't want to go and start, you can put your money in my bank, sorry, and feel the pain all the time and not be able to concentrate. But he says, if I'll come high and says, why not? Put 5 million in my bank. He probably wouldn't persuade his client either. So he wants to feel least pain as possible. Probably not, he would like to achieve no pain, but he will be satisfied with a small amount of pain, which is bearable. And it can work, and he can go to, and can function with it. Distribution. THC is highly lipophilic, and that's why it goes to the tissues that are highly perfused, such as the lung, heart, brain, and liver. And the concentration in the plasma is not actually a very good pointer to where the THC is. And that is also one of the reasons why you see it in the urine 3 weeks after one ingestion. Prolonged exposure are retaining the fat much more for longer periods of time. And this is one of the reasons why chronic users, and remember that our patients are chronic users, have a much higher concentration of THC and CBD in the lipophilic tissues. And that's why Murray et al. Is postulated that the long-lasting effects of cannabis during abstinence in heavy user may be due to residual THC and 11-hydroxy-THC concentration in the brain. For us, unfortunately, it has a benefit because in Israel, due to bureaucratic reason, you have to renew your permit, your license, every year. And sometimes it takes months to sometimes periods when the patients are between licenses. And luckily, because of this, because the long-lasting effects, they don't feel a withdrawal very often. But of course, it's not beneficial for them to have drug-free period. Metabolism. Again, the hydroxylation is done by the hepatic venue, which we'll talk about later, means that there will be interference or co-accordance with other drugs, and you have to take in consideration when treating patients, because most of our patients get other drugs. We see that it has an affiliate with warfarin and codeine and opiate derivatives, which are very important to consider when treating patients. The first oxidation usually occurs within minutes, and as you see, the peak concentration of 11-hydroxy-THC, which is the active metabolite, will occur already 13 minutes after the start of smoking. But oxidation of the 11-hydroxy does produce the inactive metabolite of a THC acid, which takes longer. This usually takes about 2 hours and 2 to 4 hours, and that's the duration of the psychoactive part of the THC. As you see, after the initial distribution phase, the rate-limiting step in the metabolism of THC is its redistribution of lipid deposits into the blood. And the elimination. 80 to 90% is excreted, mostly as hydroxylated and carboxylated metabolites. Usually takes a long time, as we said before, but the active metabolites, as I said, are within hours. More than 65% is excreted in the fecus, and 20% is being eliminated in the urine. And the slow release of the lipid storage that we already talked about is, of course, is important. What are the interpretation of cannabinoid concentration in biological fluid? As I said, plasma is mainly used for bureaucratic reasons. I don't know how to say, because it doesn't mean much about what is happening in the brain, which is our main target of origin, and on the specific disease that we are trying to treat, because usually we do not treat the plasma itself. But it's an indicator of what's happening in the body. And you can see that at least with smoking, the concentration decreases gradually with a detection time of 4.5 up to 11 hours, with the 175 and 3.5 THC concentrate that we talked about in the beginning. While oral intake has much lower than those found on smoking administration. As I said before, which means oral distribution as opposed to smoking or vaporizing distribution usually takes much longer, and that's why oral prescription are more advised by the medical doctors, because they work longer and usually have to take them only once or twice, no more than 3 times a day, while smoking usually take 4 to 6 times a day. In Israel, it's very important because you're not allowed, even if you have a permit, you're not allowed to go to smoke in the street. or to smoke at work. You're only allowed to smoke at your house, or you can have 2 addresses. So if you take it 6 hours and you have to walk around with a cigarette, it's a problem if they catch you. Usually, luckily, they don't. As I said before, excretion may take weeks, but it's doesn't have any clinical importance, only legislative, at least in Israel. You can check oral fluid, which means the how do you say rock? Yeah, in the saliva. Sorry, I'm very nervous. If you didn't notice, so my English tends to be worse under these circumstances, and I didn't take any cannabis before. An oral fluid concentrates usually correlates with the plasma cannabinoid, but at this point of time, we don't have a really good way of measuring the concentration in the saliva. That's why it's not used by the authorities, at least at this point of time. I believe that eventually it will be, especially and if recreational cannabis will come into the law in various countries, because what we see already in Colorado and Washington are debate concerning driving and when should you drive, and if they put a 5 nanograms per milliliter level, how do you check for this 5 nanogram per milliliter on a driver? Usually the policeman is not allowed to take a blood sample. By the time they will get the driver to the station for a medic to take a blood level, it will probably already go down below the 5 nanograms. But again, remember the wide intra-individual variation is a problem for us to know exactly what the levels are. So what the level means, not what the level are. And of course also for jurisdiction regions, it will be a problem. But at least what we know that the cutoff was 2 nanograms per milliliter in the oral fluid THC, which meant more than 5 nanograms in the plasma. Okay, that's actually the main take-home message of this. I didn't introduce myself. I'm deaf in 1 ear. This is a cochlear implant, and my batteries just went out, and that's why I'm blinking. This is already has been shown in various presentations, the chemical composition of the various ingredients of the cannabinoids. Very important, but everybody showed it already. What I would like to conclude this presentation is concerning the bell-shaped response for THC and CBD. Actually, it's more known for CBD. And why is it important? It means that at least for pure CBD, more might be less. We usually have a trend that if we think that the medication is good for the patient, we top the dose each time until we have the required results. For instance, antipsychotics, if I will start with Zyprexa or olanzapine, I will give 5 milligrams, and if it doesn't enough, but I see part response, I will go to 10 milligrams, 50 milligrams, 20 milligrams, but we have a level that we don't go above. Here, not only we have a level that we don't go above a certain level, actually the results get worse and not better. They even do not stay the same. That's what it means with a bell-shaped response. I'm sorry you can't see it probably in this, because you can't read what's written inside. But as you see, that at the beginning, when you get the dose higher, you get a better response, and then with a higher dose, you get a worse response. You see it in THC in various various clinical trials. All clinical trials were not done in human beings, unfortunately. Not unfortunately, but one done at least up to this point in human beings. But there's, of course, a food for thought. What is happening in a human being? What Professor Galili showed in her article, which is this article, is that probably while using cannabis, the bell-shaped response is much less obvious than when using pure CBD. maybe because of the THC content. We know already, and it was talked about in the previous presentation, that THC and CBD probably have counteracting effects. So we will, as doctors, have to decide eventually what percentage of THC and what percentage of CBD do we use in a regimen for our specific results that we would like to achieve. At this point of time, the clinical data, not the empirical data, but the clinical data is very scarce, and we don't exactly know what we would like. But I think for future trial, it's a very important question. Again, we have the same results from another study showing that as we go and elevate the dose, we get a better response and then a worse response. I would finish my presentation with a Medscape article that was published actually 2 months ago. Could you go on to the hyper connection to the Medscape on the blue? Could you press on the blue? Yeah, just a second. Yeah. And I would like to scroll down until you see the yellow subscription. Yeah, scroll a lot. Where's the article again? Yeah, thank you. That's a Medscape article. If you want exactly where it's from, you can have it in the beginning, and you can go to me in the end of the presentation. And you can see that one of the problems is that CBD causes immunosuppression. Okay? And we must be very conservative about the use of CBD, because sometimes we want this immunosuppressive action, and sometimes we don't. So we have to be very careful with what we use. Again, especially when we use high dose that potentially inhibit the responses. Okay? So again, it's something to think about when giving. As we already told, previous presentation talked about the THC and psychosis, and CBD again might be, as I said, counteractive and may work against psychosis. So there is a reason for giving cannabis with some CBD in order to elevate the major, from my point of view, I'm a psychiatrist, the major side effect or major serious side effect of cannabis, which is psychosis. Another thing, CBD may reduce the anxiety. Now, anxiety is one of the major side effects of using cannabis. When I said at the beginning that 15% of our patients that tried cannabis didn't continue, some of them because of anxiety, whether it was panic attacks or just general anxiety disorder or just an anxiety effect, that was the reason they stopped. They didn't want to have it, to feel it again. And again, when using a small concentration of CBD, you might elevate that problem, and that's why we are trying to push now, in Israel at least, to use a small amount of CBD within, even if you want a high THC cannabis strain, to use at least up to 2% CBD in the strain and not just traces of CBD, which is the state of the art now. Could you continue scrolling a bit? What we would like to talk a bit about an intranasal administration. It's a new form of giving cannabis. We are working on it now. The point of intranasal is that you see that although it's less of a bioavailable than the maximal bioavailability that we saw in smoking, the therapeutic window or the window of bioavailability is actually very small and may be much more beneficial for the patient, as we'll have less intra-individual variance. Could you continue scrolling, please? Oops. Go back to what we just had, the blue one. Okay, thank you. What I would like to warn, and this is mainly from the Colorado experience of recreational cannabis, to tell the truth, that we have a lot of adolescents who are using medical cannabis, what's its nickname, which I don't like, as I said before, because we, when I say we, at least I feel partly responsible, have broken the stigma of cannabis as a major drug or major drug abuse. And now people come to think, especially in Israel, that marijuana is only beneficial. That's why even yesterday, when Boaz Wechter said that there's no ODs or not on ODs, there are no ODs, but when Boaz Wechter said that it never killed the person, I stood up and said that it's not exactly true, because I feel that we already turned the page too fast, and a lot of, mainly, as I say, adolescents are going back to use, at least in Israel, cannabis because the stigma has at least partly been broken. There's also an unintentional pediatric marijuana exposure. We see it in Colorado as more recreational cannabis is open to the people. But we also talked about it, Eitan talked about it in his previous presentation, when you're giving candy-like or cookies-like with cannabis. Of course, children, when they see the cookie, especially when they see one of the parents eating a cookie, they want one also. And if you don't give them, eventually they get there. And it's a problem. We can see it in the emergency room, that there's an increase in the pediatric treatment of accidentally marijuana intake. Thank you very much. I will finish my presentation with this. Thank you. Dr. Resnick. Okay. Dr. Resnick is still not here, so we'll proceed with... No discussion? Oh, you want a discussion before? I thought you did that tomorrow, but okay. No, but fine. Is there any questions?
Yes, I do have, because your talk was dealing with pharmacokinetics especially. I know that there are more and more data, experimental data available, that endocannabinoid system is involved in the regulation of metabolizing enzymes, even the central endocannabinoid system. And we have to take care about a situation that people taking cannabis or cannabinoids are treated also with some other drugs which are metabolized by the same enzymes, and this could be a very bad interaction leading to very worse effects. So can you comment on that?
I think I mentioned it. I'll talk a bit more on my next presentation. But yes, since it is metabolized by the liver, there's a lot of interactions between cannabis and other drugs. And we know that drug-to-drug interaction is a problem within medicine, especially when you treat the geriatric population that usually have sort of a manual of various drugs that are taking. But we will talk a bit more about it on our next presentation. Okay? And actually, it was pleasure that I present Tzachi. No, you can come up. Because part of the question, he did a very, lovely work in a nursing home. And one of the things that he will talk about is lowering the doses or even eliminating other use of drugs or other use of medications due to the use of cannabis. And with that, even lowering the interaction between medication.
Thank you. Hello. This side is really neglected over there. There are still chairs here if you want. My name is Klein. My background is actually filmmaking. I'm a filmmaker. That's what I did for many years. And I should tell you about my first encounter with cannabis as medicine, and that was 15 years ago, when my mother was diagnosed with breast cancer and had to go on chemotherapy. And her oncologist secretly advised her to use cannabis so she can cope better with the side effects of chemotherapy. So my mother came back home. She asked me about it. I told her everything I knew back then. That was 15 years ago again. So I had just some little experience from Holland. And that was it. But she was mostly concerned about the brain damage that at that time was part of the influence of cannabis, the general knowledge, that what was known. And luckily enough, at that same year, Professor Rafael Meshulam won the Israel Prize, and I went to listen to his lecture. And it was a 1-hour lecture, not a short one like you heard before. It was a full 1-hour lecture about cannabinoids, the endocannabinoid system. For me, it was mind-blowing. It was maybe too much. And after that lecture, I went and asked him the question that my mother asked me about the brain damage. And he looked at me and said, "So you didn't listen to my lecture?" Because he was talking about the same thing, about the brain damage that can be prevented with cannabinoids and so on. I went back home, told my mother about this story, the story about the children in 1995, that they gave THC to children. And she decided that, yes, she can use cannabis, and she used it. It helped her cope with chemotherapy side effects and no brain damage. She actually finished her PhD afterwards at the age of 60. And today, 15 years later, she's okay. And I think that's the correct way to write it. I skip now several years forward. When I first met the cannabis industry in Israel, it was very, very small when it started. I joined in 2007. There was one cultivator, grower, who also dispensed the cannabis to the patient. At that time, I think there were maybe 20 patients, registered, licensed patients. And I joined in as a volunteer with this small family. I received a license, a special license from the Ministry of Health, from the regulator, and actually he sits here. And it was a bit funny how it was written, but it was very serious and we needed it. I had a license to roll a dangerous drug. And that's what was written on the license, and to educate and help patients that received license. And we had a little clinic. This is all the background for the next step. We had a little clinic. The patient used to come in, and we educated them. Of course, we rolled the cigarettes for them. Most of them were naive patients. And education included theoretical part. What is cannabis? What cannabis do? What is the history of medical cannabis use? A little bit about cannabinoids, endocannabinoid system. So the patients that came in received a little background, theoretical background, and then there was the practical part when they tried cannabis for the first time. And I will not talk a lot about it now, but we had some basic rules how to teach them to smoke. These are people that didn't even smoke cigarettes. And I must say that at that time in Israel, we didn't have vaporizers or oils or anything else. At the very beginning, we had only flowers that we can roll to cigarettes or maybe use a water pipe, a bong. Educating the patient was one thing, but the other thing was also helping those very, I don't know if sick people, very bad situation, very bad physical situation that received cannabis. So we were working with the patients, sitting with them, helping them cope also with the psychoactivity of cannabis. And very different kind of patients, all kind of And actually, this was the most rewarding thing I ever did in my life. Those 3 years volunteering with this group of caregivers. I don't have enough words to describe this feeling. A person comes in a very bad situation, very, very bad. And after we sit for 1 hour, we try the cannabis. Usually, most cases, walks out with a smile. They are feeling much better. Maybe it was a problem of appetite, maybe it was pain, maybe it was other stuff. Something was changed. They received a new medication. They received some background on it, some theoretical background. They changed what they thought before, and they're ready for their new treatment. I want to show, okay, during this time, I produced a documentary with the help of the producer. Actually, we co-produced it together. He's back there, Uri Glaser. And we did this documentary. And I want to show you just one small scene that you can see how it looked, this first cultivator, this first grower. What? Oh, can you? Yes. Me? You? Who? Okay.
אני נוסע לפגוש את ספק הקנאביס של משרד הבריאות. ספק הקנאביס הרפואי של משרד הבריאות? במילים אחרות, יש מישהו שמגדל קנאביס ברישיון עבור משרד הבריאות. וכל זה קורה במקום סודי בארץ, שמסיבות מובנות נאלצנו לטשטש את מיקומו. אהלן.
נעים להכיר.
דורית, היא מגדלת הקנאביס הראשית עבור משרד הבריאות, והיא עושה את זה בהתנדבות.
הפתעה. זה חדר האימהות.
אימהות.
מה זה אימהות? זה צמח שממנו אני לוקחת את החלקי...
כמעט כל הבית של דורית הוסב למפעל לגידול קנאביס, וגם הצמחים מרגישים שם בבית.
לכל צמח יש את השם שלו. מה זאת אומרת? שאם אתה רואה, ארז, זה שמות שלא נתתי סתם, זה שמות שנתתי על שם חולים שהיו אצלי, שבחלקם, אני מצטערת לומר שהם כבר אינם היום. אבל בגלל שאני כל כך קשורה לצמחים, לכל צמח נתתי שם של חולה. וואו.
So that's how it started, very small, very nice, very personal. Plants named after patients that were treated with the plants, and it was really nice. and the documentary portrayed a lot of patients that we knew. Yeah, some of it will be shown later today, I guess. And I just wanna show one of them because. And that's David. He's a Parkinson patient. The cannabis was, he received the cannabis for pain, not for Parkinson. Parkinson was not an indication at that time, but he received it for pain. And what he told me that, of course, it helps with the pain, but it was more than just a pain reliever. So can we play the small clip?
אני אובחנתי כחולה פרקינסון לפני כ8 שנים. וחולה פרקינסון, המשמעות שלו זה רעידות, שמלוות בכאבים.
מה עוד לכתוב?
בוא תחתום, בוא נראה את החתימה שלך.
מה עוד? אתה רוצה... זהו. זהו. יכול להסתכל?
לא שלי.
מה שאתה רוצה?
איך היד משוחררת?
שוחררת, הכל טוב. מה אתה צריך? מה לכתוב אותו?
The documentary made a lot of impact in 2009 when it was released. Maybe Dr. Baruch will tell later about the headache I gave him with this documentary when it was released. At that time, before the release of the documentary, there were 700 patients in Israel. After it became total landslide, I guess.
But as a regulator, up to this point, I had to persuade people and doctors to accept cannabis as a medical opportunity. From then on, my problem was to persuade him that it's not a miracle drug. Okay, so that was my trouble as a regulator.
When I made this documentary, I didn't know what's going to happen next, but a few things happened after. One of them, which I'm really proud of, is that a few doctors decided to do a trial, to do a research about this, and that was because of the authorization of cannabis treatment for Parkinson's disease was prompted by Israeli media reports of dramatic improvement of tremor in one patient, and that was the patient that you saw just now. So this I'm really proud of. You can look at this paper and look at it later. Just that they found that there is amelioration of both motor and non-motor symptoms in patients with Parkinson's disease treated with cannabis, and that was in smoked cannabis. And another result of this documentary, that you'll see part of it, was that one day I get a strange phone call. Hello, my name is Inbal, and I'm the head nurse of a nursing home, and we have a license here for cannabis. We want you to come and help us. I said, well, sorry, why, what? Again? And she said, one of the family member of a patient that is hospitalized here saw your documentary and decided that cannabis might help. They applied for a license. We got the license here. We don't know what to do with it. We don't know what to do with cannabis. Please come and help us. So I did. I went to this nursing home. which is a 36-bed skilled nursing facilities, and all patients have difficulties with activities of daily living. In Bal, the head nurse took me immediately to see the patient that got the license. And she was a 75-year-old lady diagnosed with dementia, extreme dementia. She was sitting, I'm not a doctor, I remind you, I'm a filmmaker. She was sitting on the wheelchair, groaning, just groaning. Her eyes were running around. And as Inbal told me, that was the situation for a few months. Nothing helped her. And she was called by the nursing team, not without affection, the tiger, because groaning and groaning. So I'm standing there in front of this patient, and as I mentioned at that time, there were only cigarettes for smoking, and I don't know what you would do. It was you cannot put the cigarette, and there was no communication at all. She was not responding to her name. She was not responding to anything, just, as I said, groaning. And I had to do something, which is, I had to actually exhale smoke just an inch from her mouth. And it did the trick. Just, seconds after after she inhaled what I exhaled, there were no groaning. Her eyes stopped running around. She even responded when we called her. And after a few minutes, she laughed. And she smiled and laughed. And that was the first time anyone at the ward saw her smiling or laughing. Well, that small experience there led immediately to another request for a license and another one and another one. And the place became... they had a lot of license there. And we couldn't go on with the same treatment methods that I introduced at the first time, and we needed something else. At that time, again, there were no vaporizers in Israel. We had to improvise something. It's a mixture of a water pipe and... yes, sorry.
At this point of time, or a bit later, of course, as a regulator, I was very much alarmed because we were afraid that in this old age home, they're actually drugging the people and probably making them unoperational at all just to help the nurses work with them. So me and the Director General of the Ministry of Health decided to pay a visit to the nursing home to see exactly what's happening there. I hope Tzachi will talk about that too, but if not, I will tell you later.
Something which is just outside of my speak at all, because I saw at the downstairs on the stairs there, this poster, there is another one, which is full with this kind of small boxes, small containers. You see them on and that picture was taken at Hadarim nursing home. Anyway, that's the smoke machine. It's actually burning the cannabis, filtering it with a little bit of water, and filling up a balloon. And actually, we have a short video of how it works from one of the TV reporters that were there.
בבקשה, רום. תכף אני מחליף לך בלון.
רום, בן ה-90, מקבל עדי קנאביס רפואי באמצעות מכשיר המותאם במיוחד לצרכיו. גופו מגיב מיד. רעידות מחלת הפרקינסון הולכות ונפסקות.
So the nurses used this improvised machine until we introduced the vaporizers there, and we used the Volcanomedic. Okay, the small place, this became a pilgrimage site for journalists from all over the world. They all came to see this wonder. because it was the first, maybe the only one in the world, the only authorized nursing home. The place, the manager, the medical manager of the place was authorized by the regulator to treat his patients with cannabis. And this is how it looks in media all over the world. And we ended up also in CNN's with Sanjay Gupta, came for a visit, and I want to show you this small clip.
Answers might come from places like this. It's a state-run nursing home outside of Tel Aviv. Residents here are using marijuana for pain, loss of appetite, Parkinson's disease, and dementia. Moshe Root is one of those residents. He was 77 when he smoked his first pipe of marijuana. He's 80 now, and he smokes a couple of times a day. It's to help with the pain and the hand tremors caused by a stroke.
So it's a mixture of tobacco and marijuana.
He even decided to light up during our interview to stop his hands from shaking.
You're saying your hands are steady because of the marijuana?
It also helped ease a deeper pain hidden from sight. You see, Moshe is a Holocaust survivor. When his wife died a couple years ago, he was haunted by nightmares of his childhood, hiding from the Nazis. The marijuana, he says, took him out of the darkness.
You dream. You fly.
When you smoke?
Yeah.
There are 19 other patients here. Scientists at Tel Aviv University are now studying their progress, and they call the results outstanding, including weight gain, improved mood, pain and tremor reduction.
So that's all. Until now it was the introduction, and I left Sanjay Gupta to do my introduction. He said scientists from Tel Aviv University are now researching, so I went back to university after many years just to do this project, decreasing the consumption of conventional drugs together with significant health improvement through medical cannabis treatment with academic advisors, Professor Dror Avisar from Hydrochemistry Lab and Dr. Yehuda Baruch from Sackler Faculty of Medicine. And the objective was, what is the effect of cannabis treatment on patient at a nursing home in terms of well-being and use of medication? And it was a metadata research on the patients that were treated by us before. 27 patient files were surveyed for use of medications, quality of life as described by local staff, and medical conditions. Cannabis was prescribed in this ward for different types of, mostly pain. Next was appetite, spasticity, Parkinson, mood, insomnia, ataxia, agitation, and tremor. But cannabis was prescribed sometimes for more than one problem. So the main ones were, again, pain and appetite. 4 types of cannabis were provided at Hadarim or were used at Hadarim. A high THC strain, more than 20% THC, with no CBD. 8% THC powder that was made from trims, mostly. 12 CBD THC strain, and a strain later that came with a high CBD and low THC. And I will touch a little bit this because we know only the differences in those strains. We know the differences that are the THC and CBD concentration. About all the other cannabinoids, terpenoids, flavonoids, we actually know nothing at this point. So we just regard the THC and CBD. Sometimes it's not enough. I think that the recreation people speak about differences between sativa and indica. And I tried to see if maybe the difference is the THC and CBD. No, it's not. They have similar percentages of THC and CBD, those strains, and people talking about different effect. Maybe sativa is more up, and indica keeps you asleep or something like that. But we don't know yet why. And the methods for using cannabis at Hadarim were mostly ingesting cannabis. Most of the people started with smoking or vaporizing. Only few of them were continued to use it in smoke. One of them was Moshe that you saw in the report by Gupta. I go back to the first case. She continued her treatment with 0.3 grams of cannabis flowers in the smoke machine. That's the weight graph for Mrs. A. The loss of weight was halted when we started using cannabis around here. So the weight was going down. This is kilograms, by the way. And it stayed stable for the first year. She started gaining weight in the second year. And during that time, she stopped using some of her medication. Not her personally. The doctor, of course, decided to lower some of the medications. And these are all medications that were stopped. Seroquel, Clonex, Phenergan, Ebixa. By the way, Seroquel is not, as a big FDA warning, not to be used with dementia patients. I still cannot understand how they prescribed it for dementia patients, because as I look at it, there is a big red FDA warning. Don't give it to dementia patients, especially old ones. And this is what is given to them. Second case was admitted at the age of 89. He was diagnosed with Parkinson's. And 5 years before arrival, he had a stroke, was confined to a wheelchair, suffered from spasticity. Saliva was dripping from his mouth, and pain. He suffered from pain, flare-ups of arthritis. He was deeply depressed and crying a lot. The nursing team wanted to find a solution for his constant pain. He was getting 3 times a day, 0.5 gram of cannabis flowers, shredded, vaporized in a volcano. And he was free of pain, sitting upright in a chair, alert, experienced a good spirit. Salivation was significantly reduced. His muscles became less rigid and less cramped. His appetite improved and he ate better. No outbreaks of arthritis, and he had no inflammations. And again, stopped using some of his medication, were cut down. And these are the results for the 27 patients. We had pain relief and discontinuation of pain relief medications, improvement in appetite and weight gain, improved eating ability. In this place, they didn't need feeding tubes. No one at the ward was with feeding tubes or PEG. Decreased in muscle contraction, improved sleep, and enema treatments that were part of the ward were almost completely halted. Just a small example of influence on spasticity. Actually, Inbal, the head nurse, calls me one night, and she said, one of our patients is doing some kind of strength meditation, because that patient was constantly like that. And after the cannabis treatment, she just opened up her hands. She moved them. And it was so nice to see. I'm a person that likes to see things. And improvement of patient symptoms. This is interesting because on one side we have the indication that the cannabis was prescribed for. And on the other side, that the results. So 18 patients that were prescribed cannabis for pain gained relief of pain. But appetite, for example, when we looked at the files of the nine patients received cannabis for appetite. But actually 15 patients improved in their appetite, and that's the follow-up in their files. So 6 others gained more appetite. Last down at the list, 0 for PTSD because it was not prescribed for PTSD. But 2 of the patients, both of them Holocaust survivors, told me, one of them was Moshe, he told me, he was a Holocaust survivor. He suffered from nightmares all the time. And a few months after he started using cannabis, he came to me and said, I'm no longer a Holocaust boy. I stopped. These dreams are gone. So that's another effect that he gained from cannabis. And the total of 39 medications were cut off, were stopped for these patients, and from different kind of groups, from anticonvulsants and Alzheimer medication and sedatives, antipsychotics, of course, pain medications and Parkinson and so on. And these are the names of these medications, in total 25 of them. And for me, again, as a person who works in the visual world, I thought that a better way to put it would be like that. And that's my conclusion from this small research in the nursing home. There is another subject with which I want to short thing. Another result of the movie, parents of a boy with autism called me. Again, after they saw this documentary, they needed help with their 11-year-old boy. He suffered from autism. He was really agitated, shouting and crying. The day I came, they told me that the neighbors just moved because they couldn't stay there anymore. He was scratching and wounding himself. He was scratching and wounding people next to him, especially his parents. No one else was there for him. He had atopic dermatitis. He was scared. He was not going to sleep. He didn't have any educational framework at that time. And as the parents told me, the situation was actually a living nightmare. And they wanted to try cannabis. They tried asking different psychiatrists, neurologists, no one wanted to help. The only person that really wanted to help them and help them was actually at that time the regulator again, Dr. Yehuda Baruch, who agreed to help this family and to give them 1 month trial of cannabis. And we started with cannabis extract. We knew what the THC content in this extract, which was 2.5 milligram THC for 1 drop. We started with 1 drop 3 times a day, and after 2 days, when there was no reaction, we went on to 5 milligrams, and in 7.5 milligrams 3 times a day, we started seeing some kind of reduction in symptoms and continued the treatment. During the first 4 weeks, we saw agitation was gone, no shouting, no crying. The skin became very clean, no wounds, because he stopped scratching himself. He stopped wounding other people. You should see his father's hands and the mother, like, okay. So he stopped wounding other people. And then we started also see smiles, maybe a little bit communication, maybe. And one thing for sure, that he slept at night. So they could also sleep at night. And then again, after 3 months, During the first 3 months, they worked on titration. It was not very easy. Sometimes the suppliers don't supply the same material. We are working on it, but... And after 3 months of treatment, we still have no agitation, no shouting and crying, clean skin, no wounds, stopped scratching, no wounding. So it's the same, it continues, but there's one more significant change, which was created eye contact. That was something new. I was like, oh, he looked at me in the eyes. And he became more verbal. And one last thing, that after 3 months, he went back to school. So this is where I say thank you, and thank you all for your attention.
I would just like to say concerning this presentation 2 things. First of all, that when I went with the Director General to the place, he wanted to see with our own eyes what is happening there. Okay? And actually the one who persuaded her was Moshe, the one in the wheelchair. He's in the picture there, because that's exactly how he looked. We didn't expect, but we were fearful that we'll see, how shall I say, sleeping beauties all around the old age home. And what we saw of active people, and especially Moshe said it, and of course Inbal, the nurse, said after him, that after he started the treatment of cannabis, he went back to be productive. And he started doing pictures, and he felt like he's reliving or back to life. So for us, it was extremely persuasive. Another thing I would like to mention, that if you see the indication, there were no dementias. At this point of time, we didn't know what to do with the informed consent needed to treat people with dementia, because, of course, you can't have an informed consent from someone with dementia. There's no sense in it. Now we are allowed to do a few trials with dementia, and we already sent the first one to Denmark for the oblivion of violence in medicine or violence in psychiatry, because we have a preliminary work with Alzheimer people on aggressive behavior and treatment by cannabis. That is the end of the presentation for this hour. Do you have any questions before we adjourn to lunch? I never understand if there's no questions, because... Yes.
Dobrý den. Jo? Já bych se chtěl zeptat, jestli je nějaká kritická dávka THC. Yeah. I don't speak English. Jestli se shodli na nějaké kritické dávce THC, kterou začínáte, pan doktor Baruch. Jako ta nejnižší, kde začínáte?
Sorry, hello? We give the translation here.
We will talk about the doses of starting treatment on the next sessions, but usually we start with a very small dose and go slowly up. As you go low, start low and go slow is the proverb that we use. But if you see, even in Tzachi's presentation, he started with 1 drop of 2.5 milligrams of THC. And I think at the beginning they increase it every day until they reach the positive signs when 3 drops a day of 7.5 milligrams of THC.
And when it was smoking at the beginning, at the clinic, with the 2-puff rule. So a patient take only 2 puffs from a cigarette, put it aside, and we wait. If there is no response, of course.
The last presentation today will be done by Yelena, and I think she will talk about it quite a lot. Any more questions? Then thank you very much. We'll meet here at 2 o'clock. Sorry, I'm sorry.
Já se omlouvám, já zapomněla, že chraptím, ale chtěla jsem se zeptat na atopický ekzém. Tady to bylo všechno léčeno přes poruchy centrálního nervového systému nebo neurologické poruchy. Když je jen atopický ekzém, dá se léčit také kanabisem nebo THC.
We believe that atopic dermatitis can be treated with cannabis. There is a lot of, not a lot, but there is some work done with ointments or creams to treat this specific disease. But as far as I know, and I think Tzachi, we can elaborate that the patient, the autistic patient that we talked about lastly, had atopic dermatitis, which also got better even when using cannabis oil and not an ointment. But if it's only atopic dermatitis and not a very large section of the body, usually face or hands, we prefer to use ointments or creams. But there's still a trial going on. In Israel, at this point of time, ointment and creams are unlawful.
Já si myslím, že to asi nebyla otázka, ne? To byla otázka, že je to centrální, takže jestli to není celkově. And the question was another one. The question was that she is informed that atopic eczema might be of the central nervous system disorder. And if the administration...
As I said, whether atopic dermatitis is a central nervous system disorder is still debateful, okay? Because we have a lot of diseases that get worse with certain ideation or thought processes. So CBT is a known treatment for many diseases like ulcer, asthma, and various others. So probably it helps with atopic dermatitis. Specifically, I can't elaborate more than I said because we don't know. As I said, we use ointments and creams for atopic dermatitis, which are very helpful. But as you saw, when using an ointment and cream, it is absorbed also centrally through the skin. And as we saw with this specific autistic child, the atopic dermatitis also improved, but it was part of an overall improvement. So I can't say whether atopic dermatitis improved by itself or it was part of a central nervous system improvement. Any more questions? This time, waiting a second. Okay, thank you very much. We'll adjourn for lunch and we'll come back at 2 o'clock.